so-called accommodative intraocular lenses. Our institution has received research grants from several companies and did research with some of the products I'm mentioning here. Well, this is a story which goes back quite a while. Already in the late 1980s, after the introduction actually of phacoemulsification, there has been research for accommodative lenses or for some kind of medium to refill the lens or things like this. And a lot of these things we're talking about today has been derived from that time. But during that time, surgical techniques, IOL material, or designs were not ready. The first people who started working on accommodative restoration were people, the so-called refillers, that worked on refilling the intraocular lens. Dr. Nishi from Japan is one of the big researchers in that area. Here is one of his latest paper that he has done. He is now capable of refilling an intraocular lens using two plate haptics that cover up for the leakage of a silicone oil that is inside the capsular bag, as you can see this here. And with that, you can actually achieve accommodative powers. So far, this has been only used in the animal model. It has not been used in the human. So it has gone a long way, over 30 years, but it has not reached the humans yet. If we go to the human patient, then we see that the next generation of lenses that we have used already the last couple of years are those based on the optic shift principle. The crystal lens 1CU and also the tetraflex on the market, attempting to move the optic slightly inside the capsular bag and by this creating some kind of accommodation. The crystal lens has been approved by the FDA, but the only results we really get from this lens are based on visual acuity testing, and there have been several analyses that the true accommodative power of this type of lenses is very mediocre or very low. Oliver Findle has proven that with this group, and there was a recent study here by a Japanese author who has also shown that there is not much true accommodation with these single optic intraocular lenses. When we looked at some of our lenses here, we can see that there are micro amplitudes, less than half a diopter of accommodation that can be measured. Here another study on the tetraflex lens also showing a quarter of a diopter of real accommodation. If we take all the literature together, we can see that most of the effect is pseudo-accommodation actually, that can give decent functional results. These patients can see quite well, however, this is not true accommodation. What is the next type of these lenses? The dual optic systems have been introduced a couple of years ago, already in 2002, the first studies, but it took till 2009 to get the final approval and the CE marked in Europe. Here's a prototype, it's a synchrony lens. It's a 32 diopter anterior lens moving towards a minus diopter lens, thus creating quite a bit of true accommodation. You can see that here in this image. With a movement of less than 0.8 millimeter, you can achieve 2 diopters of true accommodation. And it's independent on the refractive status, as a matter of fact. There have been a couple of papers working in the laboratory size on this type of lenses, like here from Dr. Ho, and also from the Latin American group, and a couple of clinical studies showing that this lens is capable of moving and getting this amount of movement, 0.8, 0.7 millimeters, and some very good results in clinical studies. I have similar experience with my personal experience. Since 2002 I was participating in studies, and 2009 using this lens in my clinic. Here are some of the results of these patients, which are used, as you see here, in the age distribution, mostly for refractive lens exchange. Here's the implantation of a lens. At first it looks a little bit awkward because you're implanting two lenses at the same time, but this lens really self-centered very nicely in the capsular bag, and through this injector it can be easily applied. However, we have to use a 4.5 millimeter incision, so I use actually this incision in order to do refractive surgery, putting this on axis so I can reduce the astigmatism. One of my criteria would be 3/4 of a diopter of astigmatism in order to get to 0. When we look at the uncorrected distance visual acuity here on LogMAR scale, 0.12 on average, it's not bad. The near acuity 0.3 to 0.4 is okay. The accommodative range here with the defocus curve, 2.5 diopter, is also okay. So this is more a lens for people who are interested in the intermediate vision and who can accept a slight near correction for longer reading. How can we achieve more accommodative powers? This is actually only possible if we change curvature. As you see this in these two models, the new lens and the fluid vision lens. The new lens is also a dual system, having a base lens which contains the basic dioptric power and a silicone oil-filled type of membrane which is put onto the other lens inside, and everything is not inside the capsular bag, it's outside of the capsular bag in the sulcus. And therefore you can get changes of curvature which can translate into 8 to 10 diopters of accommodation, which would be a real true accommodation. Dr. Alio has tested this lens already in a study. We also have used this lens. You see here an implantation, which is a little bit tricky as a matter of fact. The first lens is easy to implant, putting this in the sulcus onto the capsular bag. The second lens then has to be precisely placed in the sulcus here with these little feet put under the iris exactly in the sulcus. And you also need like a 4.5 millimeter incision size for that model. Now you see it's very well centered. You see that here on the meniscus. And in our patient, for example, that you see here, we have a patient who was had a macular degeneration, and we used these 8 to 10 diopters for a 2.5 times magnification, so it was like a low vision aid built inside the eye, and the patient really gained quite a bit of visual acuity, ending up 0.2, 0.3. Are we done? Another way to do that, to achieve a curvature change, would be the use of a fluid vision IOL. This lens has a specific channels here inside the optic. A fluid is pressed through these optics, through these haptics inside the optic here, and then changing the curvature. With that, you can also get up to 8 diopter of accommodation. A couple of patients have been used in a blind eye study. You see here the UBM picture of these channels. All this, including the silicone oil, is indexed matched, so it's transparent. Patient cannot see the details here. If we summarize this, the single optic IOLs that we have nowadays mostly work by pseudo-accommodative features and parameters. Dual optic system provides a more stable uncorrected distance and near acuity. The new lens can produce up to 8 to 10 diopters of accommodation, but still kind of difficult to use and to implant. Other approaches that go for curvature changes, like the fluid lens, are still in the development, experimental stage, but ultimately, if we want to gain this kind of accommodative power, we have to go with this type of ideas, changing curvature, things like this. Thank you very much for